All right, today's Lunch and Learn session 16 is on psychedelics and chronic pain with Dr. Jacob Aday. Really quickly, my name is Tiffany and I'm a study coordinator at the Health Equity Core. We are a group within the Chronic Pain and Fatigue Research Center that focuses on elevating the voices of patient communities in research in order to raise awareness about different health inequities and community needs. So together, myself, my director Rachel, and my project manager Vivian work to bring events like this to the community. I'm here with Megan today, who will be helping me monitor the chat. So for any of our online attendees, feel free to submit any questions you have in the chat or use the raise your hand function to be unmuted and contribute to the group discussion. The Health Equity Core is part of the Chronic Pain and Fatigue Research Center, or CPFRC for short. The CPFRC at the University of Michigan is a world-renowned research center composed of investigators and clinicians who study the mechanisms and most effective treatments for chronic pain and fatigue, including conditions that have chronic pain and fatigue as core symptoms. We aim to do a couple of different things, including improving the understanding and management of chronic pain conditions, as well as providing current evidence-based information to the public. We don't only study people with diagnosed pain conditions. Instead, we're interested in anyone at all experiencing chronic pain. And with that, please welcome Dr. Jacob Aday.
Awesome. Yeah, thank you so much for the introduction, Tiffany, and for the invitation to present today. I have a lot of slides to go through, so I'll try to jump into things quickly here and leave some time for questions at the end as well. But like you mentioned, my name is Dr. Jacob Aday. I'm a research investigator at the University of Michigan with appointments in the Chronic Pain and Fatigue Research Center, as well as the Michigan Psychedelics Center, which was formed in 2022. And just to give you a little bit of background about myself, I'm a Michigander. I'm from Holland, and I went to undergrad and did my master's at Northern Michigan University in the UP before going to Central Michigan for my PhD in experimental psychology, where I began getting involved in psychedelic research, doing theory, perspective, and review papers on the field to kind of get my foot in the door and familiarize myself with the literature. Before doing my dissertation with participants at an ayahuasca retreat in Costa Rica. Then I went to the University of California, San Francisco for my postdoc and worked in the translational psychedelic research program there, headed by Josh Woolley, working on psychedelic clinical trials before coming here to the University of Michigan in August 2023 to join the relatively newly formed Michigan Psychedelics Center, as well as the CPFRC, to assist with their studies in the intersection of psychedelics and chronic pain. And only disclosures, partially am supported by a NIH grant through the National Institute of Arthritis and Musculoskeletal Disease, NIAMS, on a T32 grant. And today I'm going to be talking about psychedelics and pain. So I'll start quite generally, just talking about what are psychedelics to begin with, and exploring their therapeutic applications that have been researched over the last 2 decades, and then go into more specifically on what's been more recently published on chronic pain in this space. So, like I said, I'll begin with what are psychedelics, and it's actually a little bit more difficult to define than you might imagine because psychedelics is not a pharmacologically generated term. It's a colloquially generated term. And so there's some ambiguity about what should be considered a psychedelic or not. So for instance, the classic psychedelics are LSD, psilocybin, which is the active component in magic mushrooms, dimethyltryptamine, DMT, which is found in ayahuasca, and then mescaline, which is the active component in the peyote cactus and other psychoactive cacti found in southwestern US and northern Mexico. And so those are definitively psychedelics. There's some debate on whether substances such as ketamine and even cannabis in some cases should be considered psychedelics. But for the purposes of this talk, I'll be focusing on these classic psychedelics and MDMA as well, which I will differentiate in a little further in the talk. And I'll also note that I'm only going to be talking about high dose models of these drugs. So there's also, many of you have probably been exposed or heard about microdosing, which has kind of caught on over the last 10 years or so. which is the practice of taking a very, very small dose of a psychedelic on a regular basis, 2 to 3 times a week. Small enough that it doesn't induce noticeable psychoactive changes, but enough to potentially have effects on mood and behavior. But what I will say is that there is not really a whole lot of good microdosing research that's been done so far. There's been a lot of survey studies of people who use these substances naturalistically, but in terms of well-controlled trials, there's only been about a half dozen or so microdosing studies, and they truthfully haven't been very promising. There's been very negligible effects, I'd say, so far in these well-controlled studies with microdosing. And so I'm going to be focusing on what's been a little bit more studied and has a little bit more evidence base around it, which is using high-dose psychedelics in a structured therapy setting. And psychedelics have pretty characteristic effects, very robust. They can lead to very robust shifts in consciousness and cognition, including changes in sense of self, mystical type experiences, which are characterized by this sense of unity and connectedness, transcendence of time and space, often feeling of ineffability, difficulty to describe the experience with language. Emotions can be amplified under the influence of a psychedelic, both positive and negative. It's not uncommon for people to have feelings of insight or deep meaning during these experiences, especially at high doses. There's very well-known and characteristic perceptual distortions, particularly visual changes. And so people typically don't have full-fledged hallucinations on psychedelics, but there will be disruptions in color and form in the environment. And when the eyes are closed, it's very common to have very vivid mental imagery. And some have described, the subjective state induced by psychedelics as being similar to a kind of lucid dream-like state. And before I go into those specific psychedelics in more detail, I'll just give a little bit of a guiding principle here, which is that psychedelics are 5-HT2A receptor agonists. And so 5-HT stands for serotonin, and 2A is just a subtype of serotonin receptor. And there's a lot of different types of serotonin receptors. But the 2A is really important for psychedelics, undoubtedly. We know this from many different converging lines of research. So first off, if you give a 5-HT2A antagonist, so a drug that blocks the 2A receptor, and then you give somebody a psychedelic, they don't have the characteristic effects. They don't have the trip. They don't have the peripheral changes in physiology. It's essentially like they took a sugar pill. And then also we know that among the different psychedelics, those that which have a higher affinity for the 2A receptor require smaller dosages to achieve the same effect, suggesting that the 2A affinity, the degree to which these different drugs attach to that 2A receptor is really important to the eventual subjective changes that occur. And then lastly, on the right here, we see that the degree to which 2A receptors are occupied by the psychedelic very closely maps onto the intensity rating. So the more 2A receptors that are occupied, the more intense the experience is. So altogether, there's no doubt that the 2A receptor is very important for the effects of psychedelics. And so it raises the question, what does the 2A receptor do? What do we know about the 2A receptor? Well, beyond psychedelic research, we know that there's a large body of evidence supporting that the 2A receptors are involved in neuroplasticity, the ability for the brain to make changes and make new connections in response to experience. And so, like with all other drugs, psychedelics hijack an innate system, just like cannabis hijacks the endocannabinoid system, opiates plug into your endogenous opiate system. Psychedelics also plug into an innate system, and in this case, it's one related to plasticity. So I'll go into a little bit more detail about the major psychedelics, starting with LSD, as it's generally considered to be the most recognizable, also known as acid. It was first synthesized by a Swiss chemist, Albert Hofmann, in 1938. However, he didn't realize that it had psychoactive properties until 5 years later in 1943, when he returned to the chemical, got a little bit on his skin, had mild perceptual distortions, which made him really curious. And so a couple days later, he took a higher dose, 200 micrograms, which is a pretty moderate to high dose of LSD, and had the first LSD trip and rode his bike home, which is why there's a bike here in this blotter paper. And that was April 19th, 1943. So that day is become to be known as Bicycle Day in the psychedelic community. And upon recognition of the very robust and intense psychoactive effects that LSD could have, there was a large wave of research in the 1950s and 60s. The company Albert Hoffman worked for, Sandoz Laboratories, made LSD freely available to clinicians and researchers. However, in the late 1960s, LSD and other psychedelics became very closely intertwined with the anti-war and hippie movements. And there was a lot of political backlash among LSD use, and there was a tightening of pharmaceutical regulations, including research, which really stopped all psychedelic research in the late 1960s. And the field was really dormant until the 1990s, when researchers began getting permission to work with some lesser known psychedelics, such as DMT and psilocybin. So psilocybin is the active component in magic mushrooms. It's found in over 200 species of psilocybe mushrooms. And there's, of course, a very long tradition of indigenous and Native American use in North America of psilocybin. And actually, when Spanish conquerors arrived, they believed that these mushrooms were inducing visions from the devil. So natives began using in secrecy. And actually, this practice became so secret that by the early 1900s, American scholars began to wonder if these hallucinogenic mushrooms even existed at all, or were they just a Native American myth? It wasn't until 1936, Richard Evan Schultes, Harvard botanist, and Wheatlander, an anthropologist, rediscovered the mushrooms in Mexico. And it wasn't until the 1950s when knowledge about magic mushrooms kind of re-entered the knowledge of the American public. And so in the 1950s, there was a married couple by the names of, R. Gordon Wasson and Valentina Wasson. Gordon Wasson was a very well-off New York banker, and as a couple, they were just fascinated by mushrooms in general, not psilocybin or psychedelic mushrooms, just mushrooms in general. And so when they heard that there was actually mushrooms that could induce visions, they were very curious about that and captivated by that. And they actually made a trip to Mexico themselves in 1957. And they gained the trust of some locals who actually permitted them to attend a psilocybin mushroom ceremony. And as far as we know, they were the first white people to partake in these ceremonies. And Wasson was so moved by his experience that he went home and wrote a magazine article that was published in Life magazine in 1957. You can see the titles on the cover of the magazine here: Great Adventures, the discovery of mushrooms that cause strange visions. And so in 1957, knowledge of psilocybin mushrooms reached the greater American public. And this is actually, reading this article is what inspired Timothy Leary, who would become a very famous Harvard psychologist and psychedelic researcher, to become interested in the field. However, research on psilocybin, like with LSD, stopped in the late 1960s. And it wasn't until 2006 that the first contemporary study was published. Next, we have DMT. It was synthesized on its own in 1931, but its effects weren't recognized until later, like with LSD. It's found in some concentrations in hundreds of different plants and living organisms. And it's traditionally used as the main component of ayahuasca, which is a plant-based tea used in Central and South America that has hallucinogenic properties. It's used in spiritual and healing ceremonies. When DMT is administered directly, it's very rapid, intense, and short-acting. So if it's given intravenously or smoked, it's a very rapid experience. It only lasts about 5 to 20 minutes. However, if it's given in the ayahuasca brew, the effects last about 5 hours, and it's a little bit more gradual. And lastly, in terms of the classic psychedelics, we have mescaline, which is the principal alkaloid in the peyote cactus, found in the southwestern US and Mexico. It's also found in some other species of cacti, such as San Pedro. And the mescaline molecule itself can be made synthetically, so you don't have to actually harvest cacti to make mescaline. You can just make it in a test tube. However, the effects of mescaline are a lot longer than a lot of the other psychedelics, like 10 to 14 hours, and so it's not ideal for a clinical environment. And has a little bit more intense gastrointestinal side effects, so it can be kind of uncomfortable as well if there's purging and things like that. And so researchers have primarily in the modern era researched psilocybin because the effects are about 4 to 6 hours, which fits kind of neatly into a workday. You can have an hour of prep, dose the participant, have an hour of doing surveys and stuff after the session, so it fits neatly into a workday. But there has been some research on mescaline, particularly naturalistic use of mescaline, reporting improvements in psychiatric issues and some health outcomes. And then lastly, we have MDMA, methylene dioxymethamphetamine, also referred to as ecstasy or Molly when used recreationally. And I differentiate it from the other psychedelics because of this methamphetamine component you can see in the name. So MDMA is kind of a psychedelic amphetamine hybrid. And so there's debate on whether MDMA should be considered a classic psychedelic or a psychedelic, but there's a lot of overlap generally. The uniqueness of MDMA is that it's less selective at that 2A receptor. And additionally, while someone's under the influence of MDMA, there's a little bit greater clarity of thought and lucidity. So during MDMA therapy sessions, there's a lot more dialogue between therapist and participant during the actual dosing sessions, whereas with psilocybin and other classic psychedelics, most of the psychotherapeutic work is done in the days before and the weeks after the actual dosing session. And during the dosing sessions themselves, they're very internally focused. This amphetamine component also makes MDMA a greater potential for abuse. So with the classic psychedelics, it's pretty uncommon for people to become addictive or show abusive patterns of use with them. With psilocybin LSD, there's very rapid tolerance. And so if you take the same dose the next day, you're not going to have the same effects, which is not very reinforcing. And also, the effects are just so intense and overwhelming that people often aren't keen on doing it again very soon. It's something that they're like, whoa, that was an intense journey, and it's not something I need to do every day, typically. But MDMA was discovered in 1912 by a German pharmaceutical company, PERC. They didn't recognize its psychoactive properties, a kind of a trend with these drugs. And it was rediscovered in the 1970s by a chemist in the San Francisco Bay Area, Alexander Shulgin. And I actually have a picture of his lab here. Right, I was able to visit his lab when I was living in San Francisco. And his wife just happened to be a psychotherapist. And so after synthesizing this and some self-experimentation, they realized this might be a useful tool in psychotherapy as it helped people empathize better and kind of let their guard down with their therapist and be a little bit more open. Eventually, MDMA became very tied in with the rave culture of the 1980s, right as the war on drugs was ramping up, and it was outlawed in 1985. However, in the immediate wake of scheduling, a group was formed called the Multidisciplinary Association for Psychedelic Studies, MAPS, to begin clinical research on the drug. And so many people assume that MDMA started as a party drug, but it actually started as a therapy drug, became part of rave culture, and then was reintroduced after that back into therapy. So those are the psychedelics. And so next question is, what is psychedelic therapy? Well, it basically is what it sounds like. It's the administration of a psychedelic in a highly structured clinical setting with therapeutic support before, during, and after the experience. And so typically, psychedelic therapy is thought to comprise of 3 stages: preparation, dosing, and integration. Kind of what they sound like. Preparation, participant meets with the clinician to build rapport, discuss what they want to work on during the dosing sessions, set their intentions, and also just to receive psychoeducation about what they might experience. During the dosing sessions themselves, usually there's only 1 to a handful, usually 1 to 3 sessions with the drug, usually a couple weeks to a month apart for each dose. But during the dosing session themselves, participants monitored by 1 or 2 clinicians in a comfortable, typically living room type of environment with low lighting, some artwork, just a kind of comfortable but not sterile space. And during the dosing sessions, there's really an encouragement to have an internal focus for the participants. So to encourage this, they have eye shades on, and also there's usually music playing through their speakers or a headphone. And that's thought to help them, not get distracted by the, perceptual changes in the environment, and to really go on an inner journey and to really, confront things that they've either been suppressing or look at their problems from a different perspective, a different point of view. And the therapists are there for support, if things get stressful or anxious, which they often do, especially during the first 90 minutes to 2 hours of the session. It's very common for participants to have some anxiety as the drug's coming on and taking effects, but that is pretty transient and manageable, and people tend to settle in after that period of the dosing session. Then lastly, there's integration sessions, which occur in the weeks to months after dosing, where participants meet with the same clinical team that they're with during prep and dosing and talk about what they experienced, what they went through, and if there's any insight that they can pull from their experience, and use that insight to incorporate and to encourage behavioral changes going forward. And so the current model of psychedelic therapy is very much a combined drug therapy treatment. However, there are, there's kind of recent pushback on this, that we should test this assumption more. And, whether the therapy is necessary or how much of it is necessary is a kind of an open question right now. And with this model, there have been some pretty promising results published in the modern era of psychedelic research. So I'll start with MDMA therapy for PTSD, as that's the drug and treatment indication that's been most studied. And it's thought that MDMA might be a particularly useful tool in the treatment of PTSD, as while people are under the influence of the drug, amygdala activity is dampened. And the amygdala is really thought of as the fear center of the brain. And so it's thought that with this fear center kind of clamping down a little bit, that people can revisit traumatic memories without becoming overcome with negative emotion. And the first phase 1 study was published in 2011 with promising results that were replicated in subsequent phase 2 studies. I'll spend most detail on the phase 3 studies, as they're the most rigorous. So in 2021, MAPS published their first phase 3 study, which found that 2/3 of their participants who received MDMA plus therapy were in remission from PTSD at their long-term follow-up, compared to just 1/3 who received a placebo drug but the same psychotherapy. And the second phase 3 trial had similar results as well. And so they submitted their application to the FDA last year because phase 3 is the final stage of research before regulatory approval. However, the FDA did not approve their application for MDMA for PTSD, and there's a lot of different reasons for that. Primarily, the unblinding that occurred. So it's very obvious if somebody's received a high dose psychedelic versus an active placebo. And like I mentioned before, the psychotherapy has been really poorly defined and not empirically tested so far. And additionally, the FDA doesn't even regulate psychotherapy. And so there's a lot of issues with the application that led to them requiring follow-up studies. And the next drug and treatment indication that's been most studied is psilocybin therapy for depression. First modern study was published in 2011. You can see the results plotted here. 1 week after dosing, each of these lines are individual participants. You see that almost everybody had a pretty robust decrease in their depression score, so much so that all these participants down here don't even qualify for having depression anymore. However, at the same time, you see that there's a clear trend that for these levels to uptick after a while as well. So at 3 months, there's a trend for their depression to go back up a little bit. However, if you look at where they were at baseline, they're still well below that. So even though they went really far below 1 week, they still have improvements maintained at 3 months, even if they are more modest. So there's an open question about the durability of these effects and what kind of maintenance dosing might need to be done to maintain effects. However, a systematic review that we published in 2020 found that 9 out of the 10 modern psychedelic studies looking at depression found improvements. And more recently, there have been psilocybin therapy studies published in some of the top journals in medicine, including New England Journal of Medicine and JAMA. And given this promise for depression, as well as the positive effects that were seen in healthy volunteers, improvements in quality of life and well-being, researchers have been curious about the generalizability of this treatment. I mean, there is kind of a notion within the field that anything that typical psychotherapy, talk therapy might be effective for, that potentially psychedelic-assisted therapy might also be something that could be efficacious. And so, of course, psychotherapy is used for virtually everything. So accordingly, there's been a lot of different directions the field has branched over the last 10 years or so. So there was a pilot study done very early in the modern era, published in 2006 for OCD that showed positive results. Now there's larger trials ongoing at Yale, Johns Hopkins, and UCSF. A lot of studies finding improvements in end-of-life distress and death anxiety after these sessions. And so it was really hard to get approval to do these studies for a very long time. But one area that was among the first to open up was for people with terminal conditions. The thinking being that, these people are terminally ill, they are going to die. If there's adverse effects of these drugs long term, they're not going to be around long term anyway. So this is about as safe as an entry point as you can do. And these people are, seeking help. They're at the end of their life and they don't have other options. They're stressed about their mortality, and there's not really a whole lot of good treatments for that. And so anything that might be able to help that is worth pursuing. And so there's a lot of early studies showing improvements in end-of-life distress. And then there's currently studies ongoing for other psychiatric conditions like anorexia at some of the major research institutes. So that brings me to chronic pain. And so why study psychedelics for chronic pain? And I'll be honest, the first time I heard that people were beginning to study psychedelics for chronic pain, I kind of rolled my eyes a little bit, thinking that, we're just studying this for everything right now. This is people are just looking at this as a panacea that's going to affect everything. And I think it's a little bit more nuanced than that, honestly, especially as I've become more involved in the chronic pain literature over the last couple of years. And so we know that there's reciprocal relationships among mood and pain, such that as people's pain gets worse, unsurprisingly, their mood tends to get worse on average. And the reciprocal is the same as well. When people have very stressful, very negative mood states, pain can be exacerbated. And so if you can have a treatment that is at least affecting that mood component, the affective component, there's reason to think that there might be downstream indirect effects on pain as well. We also know that stress and trauma can dysregulate the immune system, and that, like I said, uh, pain and even flares for things like lupus can be more exacerbated when people are stressed. Additionally, psychedelics seem to have effects on neuroplasticity, like I mentioned in the beginning. This has been demonstrated in a lot of in vitro and in vivo models, and um, it's a little harder to study in humans, but there's been some neuroimaging studies coming out the last few years that have supported that as well. And some chronic pain conditions have a heavy nociplastic component. They're really driven by um, the neural wiring rather than peripheral damage to the body. And so, especially conditions like fibromyalgia. And so, if you have a drug that could potentially increase neuroplasticity, that could be effective for potentially effective for nociplastic pain conditions. And then psychedelics also seem to have anti-inflammatory properties as well. This is another area that's been studied a lot more in animals, and just recently there's been a couple papers in humans, but there's a potential there as well. And so this is really an emerging area of research. The first papers have just been coming out over the last 3, 4, or 5 years. However, there have been a number of survey studies showing that people are using psychedelics in the treatment of their chronic pain. And so one survey study from our group at University of Michigan before I joined, however, found that in people with fibromyalgia, perceptions of benefit from psychedelic use were generally neutral, about 60% or positive, 36%, and only 3% reported that psilocybin made their symptoms worse. Another study found that a variety of pain conditions were reported to be benefited by psychedelics compared to conventional pain medications. And in terms of more rigorous studies, controlled clinical trials, there's a lot ongoing, but not a lot that's been published so far. So there's a case study with intractable phantom limb pain showing positive results. There's a group at Yale headed by Emanuel Schindler who's done a lot of studies on cluster headache and migraine. And the model in the cluster headache and migraine studies is a little bit different. They use kind of low to medium doses of psychedelics, of psilocybin specifically, rather than this high dose model with psychotherapy. And that work really grew out of citizen science. So, cluster headaches are among the most debilitating medical conditions you can have, um, and there's not really good treatments for it. But however, there's a group that kind of formed online who called themselves cluster busters, who were self-experimenting with different regimens of psilocybin and reporting their results to the group, and kind of informally doing their own studies. And Manuel Schindler came across this group during her PhD studies, and really drew from their expertise in designing the initial studies. And so for the migraine and headaches studies, they use about 10 milligrams of psilocybin on 2 to 3 occasions, and not enough to have a very significant trip, but mild psychoactive effects, and finding really marked improvements in their migraine days after the treatment, for usually about 2 weeks. And we actually published the first ever clinical trial of psilocybin-assisted therapy for a chronic pain condition last month in a journal called Frontiers in Pain Research. So we did an open label study of psilocybin therapy for fibromyalgia. Have the results posted on the bottom here. And we gave participants 2 doses of psilocybin, 15 milligrams, followed 2 weeks later by 25 milligrams. And this is a very small sample, just 5 participants, so you need to be very clear about that we need a lot more research in this area, and this is just a pilot study to examine, tolerability and feasibility. However, what we found was that psilocybin was safely tolerated by this population. There were no serious adverse effects. Some minor adverse events such as headaches after dosing, but all resolved within a day. And there were preliminary improvements in some of their pain outcomes, such as pain interference and pain severity, and improvements in sleep disturbance and physical function as well, and some moderate modest improvements in mood. Like I said, there hasn't been much that's been published on psychedelics yet, and we're kind of just starting to explore this area. So we also did a survey study about perceptions of psychedelic use among people with lupus. Did this in collaboration with Dr. Rachel Bergmans in the Michigan Lupus Foundation. And this is another small pilot study, just 23 participants with lupus in the Michigan community, primarily SLE, systemic lupus. And we just asked them about their knowledge and experiences with psychedelics. And so in terms of interest in learning more about psychedelics and how they might be able to help with lupus symptoms, most said they were somewhat or very interested. And if the opportunity existed to participate in a trial, similarly, most said they were moderately to extremely likely to participate. So there does seem to be interest in this community. And we also wanted to gauge their concerns as well. And unsurprisingly, 20 out of the 23 indicated that they did have some concerns about the treatment, including primarily side effects. Only 4 out of the 23 had actually used psychedelics themselves. Primarily psilocybin, everybody had used psilocybin of these 4. And of those 4, it was a pretty distributed response, with 1 out of the 4 saying no change in their symptoms, 1 out of 4 saying minimal improvements, 1 out of the 4 saying much improved, and 1 out of the 4 saying very much improved. But again, nobody said that psilocybin made their condition worse, which was encouraging. And when asked how psilocybin may have affected their lupus symptoms, such as pain and fatigue, 2 said no change and 2 said much improved. And I also pulled some representative quotes here from the patients about just their thoughts on this intersection of lupus and psychedelic research, and kind of 2 different perspectives outlined here. So one person said, I do not believe opening this can of worms is a wise idea. We already have so much medications already pumped through us, not to mention the potential for addiction and never being able to find that same feeling of euphoria and tolerance is building up. And so I would say some of this is a little bit misguided. As I mentioned, there's not strong potential for addiction with the classic psychedelics. And the tolerance building up is actually a good thing in that case, because people don't want to re-administer, because they just won't achieve the same effects. And another person said, I believe my mental state of mind has a large impact on my lupus symptoms, especially pain and fatigue. Using psychedelics to open up my perspective and ways of thinking has definitely helped me get my lupus under better control. I did not think about it at the time I took them, so this is all just backwards reflection. My lupus correlates closely with my stress levels, and taking psychedelics has always left me in a lower stress state. I've taken mushrooms and Molly at different times, but they all resulted in better mental state. So I also noted that I had virtually no body pains for many days after taking Molly. It was just amazing to feel that like there was nothing wrong with my body for that period of time, and kept me in a happy mental state too. Stress and bad mental health equates to worse lupus flares. I would say that people trying it need to be open mentally and not hesitant, otherwise they could end up in a worse headspace than before. I've never had any bad experiences though. So I think that's a pretty nice balanced take there. You know, noting that there is the possibility for harm with psychedelics as well, which I'm going to get into in more detail in a second here. And yeah, so that kind of blends nicely into this next portion of the talk, which is the issues with psychedelic research. And I penned a co-authored paper in JAMA Psychiatry in 2023 on this, just kind of highlighting that, yes, psychedelics are returning to mainstream science and medicine. There's been very large therapeutic effect sizes and positive safety outcomes that have led to a surge of interest. However, there's a lot that we don't know about psychedelics still, and certainly there have been distinct challenges that have emerged with the field's rise. And so I'm going to cover some of these main issues with 4 fundamental questions here. The first is how to design rigorous trials. Psychedelic studies are really hard to run, frankly. You have to grapple with all the challenges of a psychopharm study and all the challenges inherent to running a psychotherapy study, plus managing the unique issues specific to psychedelics as well, such as robust psychoactive effects that lead to functional unblinding, and significant hype around the potential benefit of psychedelics for health benefits. There's been, you know, a lot of hype that's grown over the last few years, and people come into these trials often expecting a miracle cure. And so when that expectation is paired with that unblinding, it makes psychedelic therapy studies very susceptible to placebo and nocebo effects. And the double-blind randomized controlled trial is the gold standard for evaluating treatment-specific effects, especially in drug trials. And so how to fit psychedelics into this box is kind of an open question. And, some don't believe it's even possible to ever do a double-blind study with psychedelics. There's a lot that we haven't tried yet. So I've published some papers in this area, kind of outlining recommendations for future research to do more rigorous trials. But at the same time, there is kind of growing recognition of trial design limitations more generally. I'll try to fly through this last part so we can have time for questions. Another open question is, how does it work? Already there's a lot of different theories proposing mechanisms of action, ranging from molecular mechanisms like changes in neuroplasticity and inflammation to higher level behavioral and psychological mechanisms, such as changes in cognitive flexibility, these experiences of insight, mystical experiences. And psychedelic therapy implies a combination term, including a psychotherapeutic treatment as well as a receptor-based drug action. And so, like I mentioned before, there's not a lot that we really know about how that works together. We have assumptions, but a lot of that has not been tested. And certainly there's risks to psychedelic use as well. So researchers really put a strong emphasis on preparing individuals for the experience and emphasize that, not everything that we're seeing in these clinical trials is going to generalize to recreational use because the model can look so different. These participants receive a lot of care in these trials and a lot of support. There's concerns about acute anxiety, like I mentioned before as well, especially at the onset of the drugs, the kind of 60 to the 1 to 2 hour range after dose administration. But like I mentioned, that anxiety is pretty transient and manageable, especially in a structured clinical setting. Psychedelics have pretty well-established effects on peripheral physiology, such that heart rate, blood pressure, body temperature are increased while you're under the influence of the drug. So individuals with cardiac vulnerabilities have typically been excluded from these trials in order to not trigger a cardiac event. Those with a family history of psychotic or bipolar disorders might be an increased risk for adverse events, but we need more research in that area. There's the well-known potential for a bad trip or a psychologically challenging experience. So like I mentioned before, emotions can be very heightened during the influence of a psychedelic trip, ranging from, transcendent to hellish. And so there's a lot of care that goes into, fostering a positive and therapeutic experience, including, educating individuals about what side effects and experiences they might have, having somebody there for support, and one of the most important thing is the setting as well. So having it in a comfortable, safe setting is important. People, take these in unfamiliar environments or environments that they have very little control over. There can be the potential for more negative effects and spiraling into potentially behavior that could put themselves or others at danger. People are also in a state of enhanced vulnerability and suggestibility while they're under the influence of a psychedelic, and so there have been some cases of actual psychedelic therapists' sexual abuse in the underground, and even in one clinical trial. And so this heightened state of suggestibility and vulnerability suggests that there needs to be very careful monitoring of how these drugs are dosed and with whom. And then lastly, hallucinogen persisting perception disorder, HPPD, is a potential side effect as well. HPPD is when there are lingering perceptual disturbances after the drug has subsided. And so Some individuals will have changes in sensitivity to light and color. Less than 1% of these cases, goes on to be something that, is disturbing enough to seek medical treatment for. So it seems to be transient, but the prevalence is really kind of uncertain right now. Kind of varies all over the place, partially because HPPD is not very well defined. And then lastly, there's a lot of challenges of scaling psychedelic therapy up from research trials to clinical practice. Currently, studies involve arduous screening where hundreds of people apply to be one of a select few participants in the trial, meaning that researchers can kind of pick the individuals they think are going to be the best fits for the treatment. And once that is no longer the case, we might expect the effect sizes to damper a little bit as well. It also feeds into this expectancies issue as well. When hundreds apply and you're one of the few, you kind of feel like you won the clinical trial lottery. You got into the trial, you're getting this breakthrough treatment, and of course you should get better. And so, again, these expectations are a real problem for the field. Many populations are currently underrepresented, including individuals of color, older adults, and so generalizability of the treatment is still uncertain. I've kind of alluded to the high cost of the psychedelic therapy model. So traditionally, there's been two therapists there for 6 to 8 hours of preparation, two therapists there for the 6 to 8 hour dosing day, and then two therapists there for the 6 to 8 hours of integration afterwards. And altogether, that can consume more therapy resources than most people typically use, and even in an entire year. And so the current model is very expensive, and there's really a question if this is something that could be scaled up, especially since there's already a shortage of therapists. And then lastly, monetization and regulatory models for drug-assisted therapy are lacking. Many psychedelics are unpatentable, and so is psychotherapy, and the FDA doesn't regulate psychotherapy. So implementing this into current regulatory systems is a challenge. So to conclude, psychedelic therapy has shown intriguing promise for a variety of mental health conditions, and there's preliminary support that's been coming out the last couple of years for chronic pain as well. But much more research is needed. And so at this critical juncture, I really caution against both obstinate cynicism and unbridled enthusiasm, and rather hope that people can carefully weigh the benefits and challenges that have emerged. And confronting difficult issues head on should help anticipate, mitigate risks, maximize opportunities for learning, increase the field's credibility, and hopefully facilitate research into treatments for those in need. And so with that, I'd like to also just acknowledge my mentors, collaborators, and mentees in the CPFRC who have contributed to a lot of the work that's been highlighted here today. And lastly, plug our upcoming psychedelic survey, which will launch in just over a week, May 1st, and will be available for 2 weeks. And this is a very broad survey, kind of capturing many different areas of psychedelic use, and hopefully will be very internationally representative as well. It will be available in over 15 languages. So if you are somebody 21 plus who has had at least one experience with a psychedelic, we hope you can take the survey. And thank you.